Good morning, everyone. We will start in a few minutes with Dr. DeBiase with Gaetano. And then we will have our special guest, Dr. Craig Castellino, with a special research seminar.
And I just sent the link to Craig. Apparently he hadn't gotten the link, or whatever he got was incorrect. So I don't know if we communicated with him direct, okay. But I just, he just texted me and so you guys want to get going? We're going to spend the first 15 minutes as people are coming in before Craig joins us. All right. Why don't we take it away, Gaetano, just to warm up the crowd with this short case.
Yes, sir. So we'll be spending about 50 minutes to give more space for the talk by Dr. Castellino. And this will be a case that was done by Dr. Quiñones as well as by Dr. Almeida. And you can see here the CME code. And the title of the case is, What's the Chance? So here's the multidisciplinary team that was involved in the care of this patient. And this is a lovely 6-year-old patient that in October of last year, he had an episode of acute onset diplopia, slurred speech, and right facial numbness. This prompted him to go to the ER where he had a workup with a CT and an MRI, and this self-resolved by itself in less than 24 hours. So he came to us at the beginning of this year with some disequilibrium and an abnormal MRI for a second opinion. So 60-year-old male. Past medical history was just remarkable for atrial fibrillation. And when he came to see us, he was intact, motor strength, sensation, everything was normal. All those symptoms that he presented with are resolved. And here you can see the MRI that we have. We have to the left side an axial T1 post-contrast. And you can see as we scroll up, there is a lesion there just next to the medulla, contrast enhancing, round, well-defined. And then as we go up, there's another lesion in the cerebellum right at the level of the vermis with several septation, cystic in nature, and some contrast enhancement at the level of the cyst wall. And here you have a T2 axial cuts where you can more clearly see the cystic components. I don't know if radiologists on the line, if they want to make any comments.
I don't think I see anybody from radiology here yet. So let's go down the line.
Yes, sir. Here you can see on a coronal view, and here you have the T1, where you can again see this lesion right at the level of the vermis. And then again, the round, well-defined contrast enhancing lesion next to the medulla there. So two separate,
appears to be two separate lesions, right? Let me ask one of the residents. Is Dr. Lee on the line? James, are you on the line?
Sorry, what did you ask?
No, I just want to, the first thing that I asked is whether or not you were on the line or not. So now we established that you are on the line. So let's go ahead. You have two lesions there. Were you able to see the images right there?
Yeah, I saw the images.
All right, so you have a lesion on the right shows this lesion near the medulla, and then the lesion on the left shows that lesion in the cerebellum. Give us your thoughts, as you're looking at these lesions.
This is a posterior fossa mass lesion. I think last year you said there were 3 things that you should think about, which is a pilocytic astrocytoma, medulloblastoma, or an ependymoma. I think this lesion looks like more of a, I would guess a pilocytic astrocytoma, especially given the enhancing mural nodule.
That's a bit component. So there are 2 lesions. The first one on the left does have some enhancing. I'm not quite sure it's mural nodule per se. That's the one that Gaetano is moving back and forth. And then there's a nodule in the other area that appears to be disconnected. So there appears to be 2 separate lesions. But I agree with you that every time I think of a posterior fossa, I think of the classic three type of tumors: an astrocytoma, a medulloblastoma, and a ependymoma. And then you have to look at the anatomy, of what these lesions can be. That's in the midline. The other lesion that appears to be in the medulla, I'm not quite sure it's connected, and to the best of our knowledge in radiology, they didn't think it was connected. So Gaetano, what was the differential diagnosis from the radiology readout for these two lesions?
So considering that this is a 60-year-old patient, they were favoring an hemangioblastoma. And then they also consider for this one, that separate one, they didn't think it was connected, as you said, very well defined, rounded right next to the medulla. They were favoring a schwannoma. And for the other one, and there is also the possibility of a MET, but the patient didn't refer any recent weight loss or anything. And he also had an outside chest, abdomen, and pelvis CT that was unremarkable.
Gotcha. So two different lesions. I agree with Dr. Lee. The classic 3 for the cerebellar. The other one, they thought it was, a schwannoma. I like what you're doing right there, just to see people and just to illustrate the point that Dr. Lee mentioned of, there you go, pause right there in both of them, pause right there, yeah. So you can see the one on the right is a contrast. They seem to be disconnected, the two lesions, but the one in the cerebellum maybe has what Dr. Lee described as a mural nodule, or mostly a small amount of contrast enhanced. And some of them, the astrocytomas, can sometimes have a little bit of contrast and then be cystic in nature. But this one seems to be polycystic, some small areas of contrast, and the radiology obviously, something else. And I see some questions, Dr. Castellino, you're asking for a spine MRI. You want to go ahead and ask your question? The question from, yes, go ahead, Robert. Yeah, Craig.
Yeah, I just wasn't sure if you were concerned about a metastasis there, whether you had looked, if this patient had a full spine MRI, and also if you were worried about anything more aggressive, if you've looked at like diffusion or perfusion.
Yeah, so as far as the spine MRI, sir, we didn't have that. We just had a full body CT. And as you can see here in this scan, you can see that the patient was intubated for this MRI. Actually, we got this in the intraoperative MRI suite. So the patient is severely claustrophobic, and he presented with an outside MRI that was severely motion degrading, poor quality. And we got this one with stealth right in the IMRI. We had it supine there, we scanned him, and then we flipped it prone for the case. So he was not very tolerant of MRIs.
But that's a good point, obviously. And by Dr. Castellino bringing this up of the spine. One thing that we did notice is that he didn't really have any other symptomatology, no spine, deficits or pains or anything that would indicate he was not cachectic in any way, shape, or form. And it seemed to me that pretty much his neurological exam was normal, if I remember correctly, Gaetano.
Yes, sir. So, yeah. It was found because he had that episode back in October of disequilibrium, double vision that self-resolved, and they got a CT and MRI then at the ER.
We presented this case in our multidisciplinary conference. Let's see what else we have in the case, Gaetano.
Yes, sir. So as we discussed at the top of the differential, considering the age, for the cerebellar lesion, we have to consider an hemangioblastoma and also potentially a metastasis. We have two different lesions, a 60-year-old patient, even though the CT, chest, abdomen, and pelvis was negative, or also an astrocytoma, as was mentioned, a pilocyte, even though it's very rare in this age group, or an ependymoma. And for the brainstem lesion, it was pretty suggestive of a schwannoma. So we had a surgical recommendation for him for tissue for diagnosis, also to try to resect as much as possible and further treatment guidance. There was no clear hydrocephalus, but this lesion was definitely putting some pressure there and the cerebellum. So we recommended a midline suboccipital craniotomy for tumor resection. And here we have the surgical video. You can see the patient was positioned prone.
And as you pause right there for a second, because I see an important comment by Dr. Vargas here. Gabriel, you want to make your comment? Gabriel is actually connecting from Colombia, from Bucaramanga. Go ahead, Dr. Vargas.
Yes, thank you. I'm sorry if because I am driving, but I am paying attention. Sometimes with these cystic lesions,
I think that you're coming in and out, Gabriel. Probably you're going through zones that the connection is not great. But I think that what he put in the chat is that neurocystic sarcosis is something that we see in Latin America and developing countries when you have cystic lesions. So I think that is important to put that also in the differential diagnosis. This patient was not from Latin America, it was here from the United States, but I think anywhere else in the world, this would also be as part of the differential diagnosis. I think that that's what Gabriel was trying to illustrate, you know, in our differential diagnosis that we put right there.
Yes, sir.
So,
And this patient didn't have any history of travel outside of the US.
Great, thank you.
So here, again, you can see the positioning prone with the Mayfield, and then we did a midline incision, staying on the avascular plane and starting dissecting. And then you can see here the superior nuchal line with all the muscle attachments. And then continuing the dissection there, staying on the midline. Then at this point, we proceeded with 2 burr holes. And we exposed all the way down to the top of C2, so we could see C1 and C2. And then with the foot plates, starting turning the craniotomy. And you can see here where we take out the bone flap, and this was a craniectomy. We didn't put the bone back at the end. And here, the drilling of the posterior arch of C1 to give proper exposure for the resection of these lesions.
And then what we're also opening is a little bit of the condyles to be able to open the dura. So a combination of both, we took out the arch of C1 and parted condyles, maybe about 1/3.
Yes, sir. And then here, opening of the dura in a Y-shaped and tuck up sutures. And then at this point, we brought in the microscope, and you can see on the right side, this is superiorly, on the left side is inferior, and you can already see the cerebellum and the brainstem, and here opening the arachnoid. And already you can see the tumor coming very superficial. Then at this point, starting to mobilize the tumor and see gentle dissection. And we started sending some tissue for frozen. And then we proceeded with debulking this lesion from the inside. Suction and bipolaring very gently. And then at this point, we extended more superiorly, opened there the arachnoid. And as you saw on the MRI, there were several septations and several cysts. So Dr. Q was really exploring that area. And you can see that there right deeply, he identified another cyst. And you can see here, he's removing this very thick fluid, very gelatinous in nature. And you can see it there very nicely coming out.
So that was one of the superior cysts that we have. So we went all the way up to get superior exposure to come to the edge, and then continue to the bulk and try to find the margins. And now we have a normal margin out there we see, and then we begin to come in from top to bottom, side to side.
Yes, sir.
And of course, you saw the vessels that we divided right there in the middle that were on top of the tumor. And we had, now we had, where are we right here, Gaetano?
So that's the other lesion right next to the medulla, and you can see there the pike at the medulla, and this lesion completely attached, and Dr. Q is trying to mobilize, but you can see that it is very stuck to the medulla, and there are some nerves that seem to come through this lesion. So at this point, you just went with a biopsy, and we sent it to frozen, and Dr. Argento said this looks like a classic schwannoma. So at that point, we just did another small biopsy, and we decided not to go for a resection, given the size, the age of the patient, and the involvement there with the nerves and the vessels, not to give him any deficits. And here you can see the very nice decompression. We achieved very good hemostasis, and then we proceeded with the closure we suture a dural patch, and we put some fibrin glue, and then we put also an onlay patch as well. Then, as I said earlier, we didn't put the bone back. This was a craniotomy. And then we proceeded with the closure of the muscles layer by layer. And then the skin. So Dr. Gentov is at a conference in Orlando, but very kindly provided us some slides and also a description. And you can see here.
Hi, this is Mark Gentoft. As you know, I'm the
Can you hear
neuropathologist
the
that
audio?
presents at this conference. Unfortunately, I couldn't be there today because I'm at a pathology conference this morning, but I've been able to record this for you. The first case, or this case, had two tumors. The first one that I reviewed was the midline cerebellar tumor. And this tumor has the classic histopathologic features of a pilocytic astrocytoma. As you can see, the blue arrows highlight eosinophilic granular bodies, and the red arrows highlight some of the Rosenthal fibers. As you can see, there are numerous other ones that are not highlighted here. Additionally, you can see that this tumor does not have mitotic activity, and the tumor cells here are sort of ovoid to almost spindle shape. There are two different components oftentimes in pilocytic astrocytomas. You have areas that are more dense and other areas that are looser and have more of an almost oligodendroglioma type look. This is the sort of more dense, compact area where you can see in the background we don't have any vacuolation. Granted, the cellularity is relatively low in this area, that's fine, but in the other area, you can see we have a higher cellularity. It has an appearance of what looks to be very similar to an oligodendroglioma, and it has this sort of myxoid background. It's classic to have this biphasic appearance. However, typically in books, most people show you the areas with the Rosenthal fibers and the eosinophilic granular bodies. I did perform some stains on this case. It was negative for IDH1, R132H, and it had a relatively solid growth pattern with neurofilament. And as you can see here, there are only a couple small strands of positivity where you can see some axons. So very much a solid tumor, not an infiltrative tumor. The other tumor that we had in this case was at the cervical medullary junction. And you can see there are two different morphologies to this tumor as well. We have one area that has higher cell density and one area that has a lower cell density. The higher cell density is circled, the lower cell density is the portion on the left. This isn't the best example of the Antony A and Antony B areas as far as the difference in the density, but it is present. But what is classic in this case, and we don't usually see it, this feature so well, are what we call Verricae bodies. And you can see those, there are numerous Verricae bodies within the circled area. And these are made up of palisading nuclei. This is an excellent example, basically a textbook example of Verricae bodies. So the diagnoses, the midline cerebellar tumor is a pilocytic astrocytoma, is WHO grade 1. A gene panel and chromosomal microarray was performed on the case. It was upon request. And the gene panel did show an FGFR1 mutation. This is a mutation that is non-specific. It can be found in many gliomas, but it is in keeping with a pilocytic astrocytoma or a low-grade glial tumor, especially the fact that we do not have other mutations that the panel picked up that would be more suggestive of a higher grade tumor. And the chromosomal microarray showed no alterations. The cervical medullary junction tumor, as I mentioned, was a classic schwannoma, and we did not do any further workup on that. Thank you.
And here you can see the post-op imaging. We have SCT, and the patient is scheduled for an MRI with anesthesia in March because of his severe claustrophobia. And you can see post-surgical changes there, the craniotomy, and seems like a very nice resection. So just to wrap it up on time for the next talk. The patient did very well, was discharged home on post-op day number 3, totally intact. He was just having some gait imbalance and some nausea that was controlled with medications. And adult pilocytic astrocytoma is a very rare entity. This is actually a paper that was put together by our colleagues from Rochester. And in all the years, they had only 46 cases. And there, the mean age was 33.6. Our patient was 60 years old. In their series, they were like mainly 50 or younger. And there was only one patient that was in the 70s. And they also found out also from a review, systematic review, that gross total resection, of course, as a better survival and better outcomes than a subtotal resection. So they really advocate for surgery even in older patients. And just quickly here, so it's very rare pilocytic astrocytoma, especially in adults, and also to have a concomitant nerve sheath tumor. If you calculate the odds of having both events, is very similar to the odds of winning the Powerball. All right, thank you very much, everybody, and I'll leave it to the talk by Dr. Castellino.
Thank you, Gaetano. Beautiful case, Gaetano, and thank you, Andrea. And I noticed the question by Dr. Goyal, one of our residents who I think is joining from the Southern Neurosurgical Society. Yes, and that's what I thought. I thought I saw a nerve coming through the tumor and exiting the other side. And the thing that worried me the most is when I was trying to remove it, was trying to mobilize the tumor. I don't know if you saw how the brainstem, the medulla was rotating with the tumor. So it was completely welded to the side. And then I tried to go to the medulla and see if I can find a plane to separate it from medial to lateral. And I just felt that the risk was too high to inflict danger. And I had a frozen section that appeared to indicate by a superb neuropathology that this was a benign tumor. And also I knew that we had taken another tumor out already. So at that point, I just decided to, pull out. Craig, any thoughts from your side about these two before we go to your topic? Any other thoughts that you want to teach in pearls for our residents and fellows?
Well, I'm not a great case. I mean, we see it all the time. So
Yes.
I haven't seen it in a 60-year-old. So with the schwannoma, do you worry, or did the patient have any hearing issues? Are you worried about NF2 at all?
We haven't done any of those issues, but nothing else that we found, at least intracranially. We haven't done any in the spine, but he doesn't have any symptomatology. It seems to me we had some other MRIs, if I remember correctly, Gaetano, or a CT scan. We had a CT scan from prior, I think a couple of years before, and that little lesion was there. I don't know if it was exactly the same size because you're comparing oranges to apples, but nonetheless, it appeared to have been there at the medulla. And the other one was growing, though, the cerebellum. That's why we thought that was the one that should have been taken out. So I think our concern is low. We're going to follow that schwannoma in the event that we need to. We can always give a stereotactic radiosurgery, would be very amenable. But right now, it seems to be small. It seems to be contained. He's not symptomatic from it, so we're going to hold back. I see a question from Dr. Monteser. Go ahead, Ala. Last question, and then we pivot to the next topic.
Thank you so much. Yeah, this is a very interesting case, and it's not that common to see kind of like two lesions with two different pathologies presenting all together. And that age would be considering Mets as well, but it's a very interesting case in surgical pitfalls as well. So my question was, I'm not sure if he had kind of like cervical dedicated MRI. And just want to get your thoughts. I think, there was kind of like some sort of odontoid, I wouldn't say lesion, but abnormality there at the craniocervical junction. So I'm not sure if he was worked up for that or no.
We have some other abnormalities. I think in the next MRI, we need to contemplate the idea that Dr. Castellino just brought up about getting a dedicated spine MRI just to make sure to be thorough. We have a low end of suspicion, but there are some other issues going on with him. Nothing that appears to be, extraordinarily concerning, but I think that, right now, getting the diagnosis for these two lesions, the one that was growing in the cerebellum, which was concerning for us, as James said, he suspected astrocytoma, but none of us did. You saw the differential diagnosis by the actual radiologist. I think that James was biased by my own differential in general. I think those three lesions, when anybody presents with a posterior fossa tumor, but in a patient of 60 plus, an astrocytoma was the last thing in our differential, to be honest with you. We were thinking many other things that can be more dangerous. And that's what we're going to follow him. So we'll get a spine MRI.
Thank you.
Well.
Just a comment. Sorry, I
Yes.
agree. In a person with multiple different pathologies, I'd rule out a neurocutaneous syndrome or some sort of genetic predisposition to tumors.
Yes, and I think that that's probably what we're going to end up doing. We just did that surgery a couple of weeks ago, so we're probably going to get him through the genetic testing and all that kind of stuff, just
Great.
to make sure that everything is good. Was that Dr. Aldana? I'm sorry, I couldn't see.
Yes, it's me.
Good.
Alfredo, sorry. Yeah.
Thank you, Phil. Wonderful.
Yeah.
Well,
I
don't know if you guys, thank you very much. So we had, I think that Andrea, what, before we do this, what kind of participation we have from around the world, please?
We have 58 participants from 11 different countries: Colombia, United States, Mexico, Saudi Arabia, Portugal, Puerto Rico, Italy, Dominican Republic, Panama, Ecuador, and Angola.